Good morning, good afternoon, and good evening. My name's Jane Barrett, and I am the Secretary General of the International Federation on Aging. The IFA, who's headquartered in Canada, has a long and abiding interest in maintaining and helping to improve the function of older people around the world, and in this case, Canadian citizens. And so we're here today to really talk about, IFA Vision Health Month. And as a contribution, we have three excellent speakers. One of the main policy issues on our agenda today is that of biosimilars policy. And so we're going to keep raising the conversation and the dialogue around this important policy. But let you give me a little bit of context. Vision health is of utmost importance for healthy aging, maintaining functional ability and ensuring good quality of life. You may be aware that older people are disproportionately experience vision impairment, and with population aging in Canada, alongside the increasing prevalence of chronic diseases such as diabetes, there is a need to ensure appropriate and timely vision care for all. While innovation in the vision health space is emerging, the health system of Canada challenges the very principles of access and equity due to varying policies depending upon the region. Introduction of ophthalmic biosimilars in 2023 marks an important change in policy, where governments are somewhat dictating non-medical mandatory switching in patient care. Hence, there is a need to understand and apply interdisciplinary guidance and good practices in Canada's biosimilar landscape to support access to comprehensive, person-centred vision care. Against this backdrop, the IFA is hosting this webinar to bring together three thought leaders in the vision health space to raise awareness of the importance of eye health, prevention of vision loss, and work to help shape and inform policies and practice that underpin the principles of safe, effective and appropriate treatment determined by the treating physician in consultation with their patients. And with that being said, it's my great pleasure to introduce you to three of our speakers today. First and foremost, Ms. Urvashi Rathod, Policy and Project Coordinator at the IFA, and her particular role is in leading the ICU program, advocating for options in eye health. The second speaker is Mr. Michael Riley, Executive Director of the Alliance for Safe Biologics Medicine, and I'll tell you a little bit more about Michael when I introduce him formally. And then finally, from Sylvie Caston-Gay, Executive Director of the Association of Quebec de la Dégénérescence Maculaire. And I should have, Sylvia, said that in English, which is the Quebec Macular Degeneration Association. And she'll be talking about the impact of biosimilars policies on patient care with the patient voice. So, Urvashi, I'd like to hand the floor to you to provide some context to this important topic, and I will hand the floor to you.
Thank you so much, Dr. Barrett, for the wonderful introduction to the webinar. So to get started, I am the Policy and Project Coordinator at the International Federation on Aging, and my presentation will be dedicated towards explaining about the ICU program of the IFA, which is advocating for options in eye health. So the work of the ICU program is grounded in 4 pillars. First is raising awareness about emerging vision-related policies. Second is facilitating timely access to educational resources about biosimilars. Third is connecting Canadians to experts and thought leaders in vision health. And finally, creating opportunities for Canadians to engage in discourse surrounding biosimilars in ophthalmology. So rapid population aging alongside increased prevalence of chronic diseases such as diabetes disproportionately affect the vision of older people. Unlike other chronic diseases where biosimilars presents a treatment alternative, vision loss due to retinal diseases such as age-related macular degeneration and diabetic retinopathy is often irreversible, as small variations can lead to complications due to the nature of the IV administration. Lack of awareness on biosimilars amongst both patients and physician communities due to non-targeted educational materials is a barrier to acceptance. Therefore, awareness of the emerging biosimilars in ophthalmology is the first step in overcoming uncertainty, informing clinical consultations, and ensuring biosimilar policies are patient-centered. The most advanced treatments available for eye conditions are biologics. In Canada recently, there has been a growing trend to switch treatments to the less costly alternative of biosimilars. However, this is concerning because in the field of ophthalmology, there are no studies demonstrating the impact of non-medical forced switching to biosimilars. Data is missing on safety and efficacy of switching from the original ophthalmic biologic to the biosimilar. The IFA's position on biosimilars in ophthalmology is clear: safe, effective, and appropriate treatment of eye conditions determined by the treating physician in consultation with their patients. The invaluable experiences and guidance of stakeholders in other therapeutic areas can help inform the development of an appropriate policy framework for ophthalmic biosimilars. Advocating for our position through the ICU program, we collaborate across sectors and disciplines on matters that impact the vision health of all Canadians, in particular those with aging-related vision complications. We mobilize evidence to influence policy and practice around aging and diabetes-related vision complications. And we've created a platform for knowledge exchange for a patient-centered approach to biosimilars policies, which protect and respect the rights of patients and their caregivers to make informed decisions regarding their vision health. Biologics and biosimilars both play an important role in the treatment of retinal diseases and improving access to these treatments. There is a lack, however, of scientific data on the impact of forced switching from biologic to biosimilar in the field of ophthalmology. And the choice of the treatment should not be directed by cost, but it should be based on an informed discussion between the patient and their prescribing physician, with a focus on treatment goals, safety, efficacy, and associated risk, while ensuring that the vision of patients is not compromised. Prescribing physicians should be able to request exemptions for stable patients to remain on the biologic reference product, because it can take from months to years to stabilize a patient on the eye medication. Preserving vision in the management and treatment of retinal diseases is unlike other conditions where biosimilars are applied, so it deserves special considerations in biosimilar policies. The work of the ICU program started since 2016 and has generated a number of knowledge assets, including technical reports, physician statements, and press releases. Last year, the IFA hosted a roundtable on emerging trends for ophthalmic biosimilars policy in Canada, bringing together thought leaders to discuss about the biosimilar landscape in Canada and what the future holds for eye care. We have also made submissions to INIS for evaluation of new therapeutic drugs in ophthalmology, and we continually engage with partners through social media and campaigns, such as the current one on Vision Health Month. The health policies that impact the treatment of eye conditions should be evidence-based and inform and enable informed decision-making. Patient-physician education alongside clinical dialogue are important to build confidence in ophthalmic biosimilars. We advocate for the development of tailored policies derived from consultations between patients and their physicians that support safe, effective, and appropriate treatment and management of eye conditions, along with the creation of evidence-based educational materials, guidelines, and protocols for patients, their healthcare providers, and their caregivers. Emerging intelligence is needed to better understand biosimilars in this new therapeutic area of ophthalmology, such as studies on the impact of forced switching. Finally, IFA helps build capacity across sectors and disciplines to address knowledge gaps and amplify collective voices of older Canadians with eye diseases, along with the retinal specialists through the ICU program, which provides a platform for connection, engagement, and knowledge exchange for patient-centered approach to biosimilars policies. Thank you so much. And to find out more about the ICU program, feel free to visit our website.
Thank you very much, Urvashi. You've really set the scene extremely well. You know, why IFA is involved in vision health, the context of vision health and aging, and also people with chronic diseases such as diabetes. But more importantly, how we advocate across sectors and across disciplines. You know, what we want is evidence to action. And that's why having Mr. Michael Riley with us today is of the utmost importance. Now, Michael, you've had more than a decade of experience developing and implementing health policy in the federal government in the United States. And you've served as Executive Director of the Alliance of Safe Biological Medicine since its inception in 2010. But before that, you know, you really had quite an illustrious career serving as the Associate Deputy Secretary at the United States Department of Health and Human Services from 2005 to 2008, you know, primarily responsible for policy development and implementation and regulatory oversight for issues involving the Centers for Medicare and Medicaid Services and the Food and Drug Administration. So you have served as a Senior Advisor to the Assistant Secretary for Public Affairs, the Assistant Secretary for Planning and Evaluation at HHS, you know, in the early 2000s. And you have been quoted in a number of publications and co-authored many articles on biosimilars. I think one of the important aspects of your career is your ability to build relationships across sectors and across disciplines, you know, in many countries of the world, you know, with Health Canada, the European Commission, the European Medicines Agencies, as well as the Italian and Spanish Ministries of Health and the World Health Organization. It was our good fortune to actually join with ASBM, you know, in supporting the development of a survey around biologics and biosimilars and the views of physicians. So I'm going to hand the floor to you, sir, to provide some interesting information around the current policies and the perceptions of physicians. So I'll hand the floor to you and I'll do my very best to share the screen.
And thank you for that overly generous introduction. I don't need to say any more about who I am. She said everything other than that I have 4 children and 3 golden retrievers. So we'll just continue on. So as Jane mentioned, we are a member, well, we have done a lot of work in Canada, I should say. We have really worked collaboratively with organizations all over the globe. It has been our privilege to work with the IFA, and we have been a leading member of the Canadian Biosimilars Working Group, really working on the issue of biosimilars in Canada well before, going back probably to 2012, but well before all of the non-medical switching began in the provinces that has been really moving too quickly across Canada. So before I get into the survey, specifically a survey for ophthalmologists that was jointly done between IFA and ASBM, I wanted to provide a little bit of context. And I want to just compliment Urvashi on her presentation for really hitting a lot of the key issues as they relate specifically to the eye treatment, obviously, and that is going to be the focus. But just for context around biosimilars, obviously, they have been around for a while, first in Europe, beginning in really 2006. They are very effective. They are highly similar, but not identical. So they are not generics of biologic medicines. And previous to the last year, were fairly prevalent in rheumatoid arthritis, psoriasis, UC, Crohn's disease, and cancer, and are only now becoming available for ophthalmic conditions. I think one of the greatest misperceptions and really misinformation in the beginning, since the non-medical switching policies have begun here, first with BC and then Alberta, has been the use of Europe as a comparison to what the Canadians were trying to do. Specifically talking about the uptake rates within Europe, back to the previous slide. If you could, there you go. Comparing the uptake rates, and there's many reasons for uptake around the various countries. And we have done a lot of work in Europe, including a very extensive number of European surveys with physicians there. But the greatest disconnect in terms of the information and the way the Canadian approach, which is really just forced switch policies where the government dictates what it is that you will be reimbursed for and what the patient is going to get, and takes the physician and the patient out of the equation. That's a very different approach than the European approach, because in Europe, the physicians are very much involved in the decision making. And so that's something to remember as we move forward with regards to thinking about the Canadian versus European and US approach. So the reality is, again, I think the beginning of the BC switch policy was talking about catching up with Europe. And we have focused on educating Canadians about what it means to catch up, what you're trying to catch up with. And in order to emulate Europe's success, you need to understand how Europe has gone about introducing biosimilars and the difference between what the Canadians have been doing and what the Europeans, and again, the US has much more followed the EU approach, not at all anything similar to what Canada has done. So just to talk about the US, here we are definitely catching up with regards to the European uptake rates. You see here 80% for filgrastim, 60 for rituximab, 40 for infliximab, and 21 billion in savings in the past 6 years alone due to biosimilars. But what I want to do before I get into the survey that we're here to talk about specifically with the ophthalmologists is to just talk about the survey work we've done before, and to show that the ophthalmologist survey is very consistent with surveys that we have done with many other specialty groups and with many physicians. So large number surveys, we see very similar information. This first slide, though, just talks about that physicians have very high confidence in biosimilars and are very comfortable prescribing biosimilars to new patients. You see 79, 84, you see 89% is a US survey that was only 2021. So just establishing that physicians are comfortable and confident in biosimilars. The issues that and then the difficulties really arise when you start talking about non-medical switching, and in particular, the Canadian approach of non-medical switching, which quite frankly is actually not allowed in many European countries, where you have the government dictating one product, basically not reimbursing innovator products and so on. So now you start getting into majority of physicians. Again, these are 3 surveys, a Canadian, an EU, and a US, showing that they are not comfortable. So this compares with being comfortable with switching. They are not comfortable with third-party non-medical switching. You see the Canadian results. That's 2017. Again, this is the importance of this showing these other surveys is that because the N is lower on the ophthalmologist survey, the reason is it was done as an addendum to a Canadian survey where over 400 physicians were surveyed, and ultimately reflects the same consistency of data to demonstrate physicians' perspectives. And they are definitely not comfortable with third-party non-medical switching, which is what we're talking about. In addition, again, this actually adds in a Latin American survey as well, and we did an Australian survey as well. And we see the consistency. Physicians worldwide agree that the physician, should have the ability to prevent a substitution that is done. And obviously, this is not the case with the Canadian system. Forced substitution policies is the Canadian approach, really modeled after no one, quite frankly. We know British Columbia is where it started, Alberta, New Brunswick, Quebec, obviously now Ontario. Again, very stark contrast with Europe and the US. Automatic substitution of biosimilars is generally not permitted at the pharmacy level in the United States, with one exception, which is when they are approved as an interchangeable biosimilar, which in the United States means something different than the use of the term interchangeable anywhere else in the world, because we actually have a regulatory standard, which is a higher standard. If a biosimilar is approved as an interchangeable, that means that it has undergone switching studies. And there's actually been an attempt recently within the EU to use the term, I would say co-opt the term interchangeable in recognition of the fact that it means something specific in the US. And recently the EMA in October and again in January put out a statement that said that they consider all biosimilars to be interchangeable. Again, that is not a scientific designation. That is really a public relations designation. Just as a reference, we conducted a webinar July of 2022, so not a year ago, on non-medical switching of biologicals and biosimilars, Canada and Europe and the US. There's the QR code there. You can get that on our website if you're interested. And it very much focused on the difference, really the difference of what Canada is doing compared to what the highly successful US and EU have done. So obviously there has been quite a bit of opposition within physician groups with little effect, quite frankly. The opposition from physician groups and the opposition of patient groups has, Canada has kind of continued to move forward in province by province. And back to, I think, a piece, something that Jane mentioned, really without any evidence. There's been nothing, and it really was never intended from the beginning with BC and moving through the provinces. There was never really any attempt to be able to capture data specifically to share exactly what's going on with the switching policies. They proposed some things like monitoring hospitalizations, and of course that was proposed right before COVID hit. So there's all kinds of difficulties with regards to anything that they propose to be able to document or track adverse events that might result from switching, but there really has been not a lot of data presented yet, and certainly none within the ophthalmic space. Now getting to the Canadian Ophthalmologist Survey, really, as I mentioned, this was an addendum survey, so we wanted to kind of build onto the other. There were more than 10 specialties in the original survey. We wanted to focus in on ophthalmics because of the fact that previous to this survey, there was really no need to survey and include ophthalmologists because biosimilars did not exist in that space. So this survey was done jointly between IFA and ASBM. Again, I mentioned the number was 41. Neither were identified as the sponsor of the research, and it was conducted in October/November of 2022. As is the case, so the first thing is the setting type. You look, community setting 27, academic medical center 22, and private family practice 20%. That's the bulk of where the practice types they came from. And more than 50% of respondents were from Ontario, which we thought was important with regards to making sure we're reflecting Ontario, because that's really the policy that we're talking about here. This is something that ASBM has always required of their surveys, and that is basically that if you do not prescribe biologics in your practice, you do not participate in our survey. It opts you out of the survey essentially, and that's certainly true with the one that we just conducted. So just to go through some of the specific questions, and again, I think they reinforce some of Urvashi's presentation and some of Jane's discussion, but how do costs of the public system impact which biologic drug you prescribe? This is just where a physician has the opportunity to prescribe specifically. Majority, 63%, prescribe the most appropriate drug for the patient. 37% considered cost when prescribing for the patient. So it really is what is the best particular medicine for the patient without the thought of cost. How comfortable are you in prescribing biosimilar to a treatment-naive patient? You see here, 83% are comfortable prescribing a biosimilar to a naive patient. And that is very consistent with all of the 15 surveys that we have conducted in the past going over the years. So very comfortable, which means there's really no education level for the physicians in understanding biosimilars. So you see here, this is just the kind of looking across other, the Canada one, the numbers there, 83. This is the Canadian survey, the US survey, and the Europe survey with that particular question. And you see very consistent across all of those. And those other three surveys would not include ophthalmologists, obviously, as I mentioned, because there were no ophthalmic biosimilars. How comfortable are you with the switching a stable patient from one medicine to a biosimilar? What's important to note about this particular question is it's 62% were comfortable switching a stable patient from a reference product to a biosimilar, but that is a physician-directed switch. So it's very important to understand that the context here is this is a physician-directed switch where the physician is involved in the decision-making. This is a question just about the importance of patient education on biosimilars prior to switching a patient to a biosimilar. The way we would categorize this, really 86% considered patient education on biosimilars to be important if you combine the categories. So back to, I think, what Jane and Urvashi talked about, obviously you're talking about a completely new disease state and population that really is lacking, and that's something that has been an issue across all biosimilars, the need for education. There's a lot of catch up that needs to happen in the ophthalmic space for obvious reasons. The importance of DAW, that is to be able to dispense as written here, 88% say DAW authority is very important or critical. So that means the physician basically has the ability to prevent a switch. So this is in a situation where a payer has the authority to require a patient who is stable on their current biologic to switch to a biosimilar. 91% said the ability to prevent a forced switch is very important or critical. So again, back to DAW, that has to do with before the switch occurs. And this has to do with, what they can do to prevent a switch from happening, 91%. So consistent with the previous slide. This issue is around notification. How important would it be for you to be notified by the pharmacist that your patient has received a biologic other than the one you prescribed? If the patient were receiving chronic repeated treatment, 91% said notification of a switch was very important or critical. And I would just on that one note point out that in the US, where we do only allow automatic substitution for interchangeable biosimilars, it still requires notification generally within 72 hours of the physician by the pharmacist. How important is it to you to have the sole authority to decide together with your patients the most suitable biologic medicine for their disease? 90% said physician and patient retaining sole authority to decide most suitable treatment is very important or critical. Again, really want to reinforce the fact that this survey and the results of this survey are completely consistent, and I would offer anyone to go on to our website, which is safebiologics.org, and look across the multiple surveys that we've conducted over the years to see the consistency of this particular survey with the results of those other surveys. Physician, how comfortable are you with personally switching your patient to a physician for non-medical reason? This is 66% are completely or somewhat comfortable with a switch. Again, this is the physician switch that I mentioned before. So this is not, and this is basically a physician being involved in the decision, but it is for potentially non-medical reasons. But at least their comfort level and the difference between the physician on a where they're involved in the switch versus a government entity making the switch is obviously that they are connected to, if not the decision, the monitoring of the patient. How comfortable are you with a third party switching your patient to a biosimilar for non-medical reasons? Basically, 81% are uncomfortable with third party non-medical switching, which is exactly what is going on in British Columbia, Alberta, the rest of the provinces I mentioned, and now obviously being talked about and moving forward in Ontario. So ophthalmologists are, again, this is looking at across surveys. Ophthalmologists are somewhat less comfortable with third-party non-medical switching than in other surveys, but the concerns are fairly consistent. There are reasons why you could say the N is lower. Maybe that comes into play. Also, really ophthalmology and in the ophthalmic space, because of, I think Jane mentioned this, but it might have been Urvashi specifically about the ability to come back from, if you have a disease that progresses, there's obviously considerable risks with regards to the eye in terms of being able to recover any lost efficacy during, the switch. If a patient's treatment gains were risked by switching to a biosimilar, would you be supportive of a patient's right to choose the appropriate treatment for their individual circumstance? 76% would support the patient right to choose that if the treatment gains were risked. Frankly, I'm surprised that number isn't even higher. Obviously, this is just looking at the overall approach the Canadians have, which I've mentioned several times, which is, multiple products, innovator and biosimilars reimbursed, biosimilars are encouraged, no automatic substitution. 78% want what is the actual EU approach, not the approach that is being sold in Canada as the EU approach. So the key takeaways here, Canadian physicians and patients have consistently voiced strong concerns with forced substitution policy. This is really consistent with globally opposition to the idea of the Canadian approach. Obviously, that's reflected in the ophthalmologist survey findings. Ophthalmologists, like really all specialties, are confident in biosimilars and willing to prescribe them. But like their counterparts in Canada, they strongly oppose forced non-medical switching by third parties and wish to be able to prevent a switch when appropriate. The European biosimilar experience in particular shows that forced substitution is definitely not necessary to achieve high uptake in savings. Ophthalmologists prefer a European style approach, 5-1, over the forced substitution policies currently being enacted. And Canadian patients, of course, deserve no less than their European or US patients. Oh, there's just some additional resources on a number of these issues. We've written quite a number of white papers that are in Gabby Journal, and there is the QR code.
And thank you very much, Michael. I think what really struck me to begin with was the consistency across your studies. That there is very little deviation in terms of your findings, which I think is critical. The other aspect, which really struck me was that, the governments here in Canada talk about, they focus on the economy, the economics. And if you look at the European model, that, there is a significant savings, with the implementation of biosimilars, but it didn't mean that there was forced switching. And I think that's a critical. Of course, the survey also gave us a very, very clear glimpse into physicians, and patient care and patient outcomes comes first. And I think that's really important. One question that I'd just like to pose to you now while I bring up Sylvia's slides is around this word stable. You used it a number of times, and I've also heard from physicians, one of their great concerns is it can take quite some time for a patient with, retinal diseases to become stable on their treatment. And there is some concern, rightly so, of in the forced switching that, the patient who is not so stable, they will actually start to lose, that they're at higher risk. Could you just make a comment on that? Because I think it's an important point that we need to bring out.
Sure. I think the one thing that you hear very consistently, and I can say that, talking with physicians in Europe, in the US, Australia, Canada, even Latin America, the one thing they say is that it's a journey to become a stable patient. And it's a process that you have gone through in order to get there. And you have already tried different things, and what works, and you don't want to switch. One of the biggest issues I think within biosimilars has been that oftentimes to an individual patient, say in the US as an example, a biosimilar gets introduced at a 15% difference in price. To an individual patient, there's no incentive to be switching when you're stable for a 15% price savings, even on a large, fairly expensive product, because ultimately your health is more important. So it's being looked at more as to the government to basically aggregate the savings across patients without taking into consideration the impact on a patient by patient basis. And so very consistently, there's been this attempt to basically say, look, what we do with a stable patient is very different. We're fine with a naive patient because they've never received any treatment. And it may even be considered step therapy if you're really saying we're going to put you on a biosimilar first. But physicians are more accepting of that concept than they are of a patient who they and the patient and the physician have invested this journey to get to where they are. And this is obviously something that back within the ophthalmic space could be even more problematic, because you don't want to, find out that you're switched to a product that is negatively impacting your treatment, moving you from being stable, and you're never able to regain whatever vision loss you might lose during that process.
Yeah, look, thank you very much for that very clear explanation. Now we're going to hear from a person that represents patients. So Sylvie Caston-Gay, Executive Director of the Quebec Macular Degeneration Association. And Sylvie, you also shared with us that you have dry macular degeneration yourself, and you've been leading this association, for about a year. And before joining AcuDM, you held management positions in public relations and partnership development in the field of business services, in the association sector, and in the health sector. You've also defended numerous causes as president of board of directors and have experience in several groups, and has a mutual aid and mobilisation to achieve great things, even with small means. And we certainly know that small means when we work for NGOs, don't we, Sylvie? It's a great pleasure for us to have you with us today. Sylvie, the floor is yours. Thank you.
Thank you, Jane, for having me on this panel. I'm very pleased to have this occasion to talk about what I call the patient's voice. Of course, it is the experience of our association in Quebec. So in a few words, Quebec Macular Degeneration Association, we estimate from the last statistic from Fighting Blindness Canada, that in Quebec there are 500,000 people affected with macular degeneration. A lot of people don't know it because they did not have a diagnosis from a physician. Our association has been founded more than 30 years ago. We have more than 4,000 people who are members. And in Canada, I think it is the only patient group, especially for macular degeneration. Next slide, please. We have four main objectives in our association, which is to regroup and develop mutual aid between people affected by the disease and their caregivers. We have a mandate to build an awareness around the disease and to inform our members regularly, to refer our members to the community groups and health organizations, because it is not all people with macular degeneration will become legally blind, but the disease can be very difficult in terms of anxiety. And of course, because you don't know what will happen, especially with the wet AMD, and which is treated with the injections that we talk about with the biosimilars. And we represent the patients in the decision-making bodies. So we currently see a few issues with the biosimilars, but more globally with all the new treatments that we see coming in Canada and globally, it is really a new environment for patients. What we see, and I think it's not common only, it's not something only in our province in Quebec, but when we sit as a patient in an ophthalmologist or a retinologist a clinic, they don't have much time to talk with their patients. So what happened, especially with the injections, it can last 3 minutes, 5 minutes, and there are so many people in the waiting room. So there is a real lack of understanding about what's happening with the drugs. And especially what we've seen since we talk about the Biovis, which is the biosimilar that will replace Lucentis in Quebec, and we're expecting it in 3 months, is that we don't know really how it will work in the clinics. But we think that patients need to be well informed and reassured, because we're talking about our vision here, not only about the costs, not only about what is discussed among the specialists. And we are really preoccupied about what's happening with the biosimilars, but not only with the biosimilars, but all the new the new brand name drugs. I don't know if it is the right word in English, that are coming and are announced in Canada, and it is the case in worldwide, with the drugs from the new drug from Bayer, the new drug from Roche, the biosimilar for Eylea. So we see a lot of discussions, and so what will happen? So now we have this discussion about a biosimilar, and what we see, as you've discussed, is that the physicians clearly have decided, after discussing with the government, what we see that many physicians in Quebec, many ophthalmologists and retinologists have decided to switch their patients from Lucentis to Eylea, which is the drug from Bayer. So they've made a decision a few months ago. So they've decided themselves to make that decision. I don't know if it is because they wait and see for what will happen in the future, but many of them have made that decision, and they have a certain control about the decision. But what we see is that BioViz will be forced on patients and physicians in a few months. But from my discussions with the president of the board of the Quebec Ophthalmologist Association, they have first defended a position that they should make the decision in consultation with their patients, but they have decided finally to approve, I think, what government has decided. So what can we do as patients? We've put a position in our newsletter and a year ago and a few months ago, saying that we believe that this decision has to be made by the treating physician in consultation with the patient. But what we currently see in Quebec, and I understand that it now the case also in Ontario, is that it will be forced on the patients. But we believe that we have to work in collaboration with the physicians, because we at least have made a certain an advance with the physicians to work with them. We did not have this type of collaboration in the past. So we think that if something happens, we at least have built a dialogue with the physicians, which is important. And because what we see is that when the patients and the caregivers are anxious, they had a bad, something bad happen to them after an injections, they call our association more and more. And at least we have this link with what's happening. So, and we use many means of communication, webinars, conference, newsletters, our website, we will have a new website in a few months to be more flexible and be able to give more information to the patients. And we are monitoring innovative treatments and what's happening with the biologics in collaboration with a medical advisor, Dr. David Lederer, who is a retinologist in Quebec. We issued an opinion during the evaluation for BioViz from Ines. They have put some consideration to our position that I gave you, but I have to tell you that yes, they said that they are concerned about the patients, but they still made a decision to force the biosimilar to the patients. And we insisted, we wrote a letter, we are trying to have a meeting with the Ministry of Health about the biosimilars and share our preoccupation about what will happen in the future with all these new drugs coming, which is not, as you all said, it's not because we're against the biosimilars or against the new drugs, but what will happen, you know, we think that as patients, we have to be educated, and we have to be confident about what will happen with the treatments we get, and especially with the injections. We know that it is difficult for patients to get these injections monthly or bi-monthly, so we should be considered in the decisions. And we are pleased to collaborate, which is a new thing for our association, to collaborate with IFA and associations in Canada in the vision environment. Just a few words, just to show you a few things we're doing. We have what we call Living with AMD Pro program. So we distribute flyers and posters in ophthalmologist and retinologist clinics. So at least people can call us. And we think that in the future, with what's happening with the biosimilar, we still don't know what will happen in 3 months. Will it be only the biosimilar? Will it be imposed only for the patients who get Lucentis at this time? Will all new patients get Lucentis, not Lucentis, but the biosimilar for when it is forced to replace Lucentis? We don't know yet. And we are really preoccupied about what will happen. But what I see from my discussions with physicians, they still don't know. We are still waiting for information. So we had a few weeks ago an awareness campaign for the AMD month, the AMD awareness month. And for us, it's important because at least we can build our membership. People can know that we are there, even if we don't know what will happen at this time with the biosimilar and the new drugs coming. We are building our unique force and our unique voice. So for us, our discussions among patients and in our board of director and what will be discussed at our general assembly with our members is that we are preoccupied with what's happening with the forced switch, but we see that the physicians have seem to have made a decision to go smoothly with the change. So for us, we are trying to balance free access to safe treatment, including the biosimilars, with the economic and other considerations. And other considerations, we mean by that, of course, part of these considerations are the patient considerations. And the cost of, we understand that cost is important, but it cannot be the first thing to be considered in the decision making, and we should be part of the consultation. So let's work together. I'm really pleased to hear what I hear this afternoon, the surveys and what you're talking about. I think it's important to have this shared voice. Thank you.
Look, thank you very much, Sylvie. And since you've become the Executive Director of AcuDM, I can tell you that the partnerships and collaborations that you have been able to develop, across Canada, not only in Quebec, have made a powerful collective voice towards positive change. I truly believe that by working across sectors and across disciplines, in developing a common agenda that we can come at from different perspectives, then the vision health of all Canadians, but those most at risk, will be at the heart of what we do. I'm particularly pleased to hear about, that a policy may be in place, Sylvie, but you have such a strong patient membership that they will call you, to share their perspectives, because I think that's critical, as part of advocating. What we have today is, Mr. Michael Riley, ASBM, the consistency of data, evidence on the ground in Canada and across, many countries. And then the patient voice is equally powerful to add the real life experiences to this evidence. And so it's about continuing to work towards change. As we wrap up this session, I just want to go to each of you and ask, what is your single takeaway message for the audience with us today, but also going out, as we move forward in this journey? And, Michael, Sylvie, and also Urvashi, we've all said, that we believe in the position of biosimilars, in our environment. We believe in that, but we also have particular concerns around, in the area of ophthalmology. So IFA's position is certainly safe, effective, appropriate treatment and management determined by the physician, treating physician in consultation with their patient. So I'm going to, in reverse order. So Sylvie, what's your single takeaway message for us today?
Well, I think as a patient, I think include the patient in the consultation, because in the end, the patient will pay the price of any decision that is made on their body and their eyes.
I think that is the clip of the day. The patient will pay the price for decisions that government make. And also, as we know, it's not only the patient, it's the family, and it's the economy. Because
Exactly.
It doesn't matter what age we are, we all want to make a contribution. So I think that patients will pay the price. Thank you very much, Sylvie. Michael.
Yes, I think that as Sylvie mentioned, the physicians and how they seem to be going along with the policy. I've been involved in biosimilars going back to 2010. One thing you see right away is that the physician community, there is a point, and I say this from the perspective of having helped run the Medicare program, where physicians were, the reimbursement issue is one that's always important. The physicians ultimately are going to be reimbursed. And there's a point at which you see physicians basically saying there's nothing we can do about it. I've said in Canada for years, be careful how much, to the patient groups, be careful of how much you tie yourself to the physician community, because ultimately they just get to a point where they recognize that they can no longer fight the fight. So it isn't that they're going along quietly, it's that they just don't think there's anything they can do about it. So in that case, it really does require the patient to kind of continue to move the ball forward and make, it's nonsensical for any policymaker to argue that patients or physicians are better served when the government is making the decision about what the treatment is. It's nonsensical. It's not logical. And ultimately, I've been shocked and appalled at the Canadian, beginning with BC's approach on biosimilars. And I would say that it does not necessarily portend for long-term success. It doesn't show satisfaction in biosimilars. It shows that basically you are telling patients and physicians what you're going to use, and there's nothing you can do about it. That's not how you build long-term success. And I'll finally close with this. And right before the pandemic, we did a European survey across 6 European countries. Clearly, Europe has more familiarity with biosimilars than any other place in the world. And the presentation was, I did the presentation at ESMO in Barcelona. And what the European audience, and it's European physicians and certainly mostly in cancer, but what was most noted is that as the knowledge comfort went up with European physicians on biosimilars, so also did their urgency to maintain control over decision making. So you can't connect it to lack of education, or they're not comfortable with biosimilars. Obviously, it's incredibly high in Europe, and yet they were even stronger than in the US. Physicians in Europe believe that they should be involved in decision making, and I think that's something that the survey work consistently shows. And I think it's something that, this smaller ophthalmic survey reinforces that. And it's really important to keep the physician, if they're not going to come forward, then that's why I think surveys are important, because they can demonstrate what their thinking is, even if they're not out there engaging with policymakers.
And that's very true, Michael. I think also intrinsic to what you said, and also Sylvie, is the trust. We trust our healthcare professionals.
Right.
And so when there's tension that's experienced, between patients and healthcare providers, because decisions that they may not know about, or decisions where we're not well informed, then that really starts to erode trust. And I think, that's critical, to having a very clear pathway to safe and effective treatment. Urvashi, you have the last takeaway message for our audience today.
Thank you, Dr. Barrett. So, as the IFA and the ICU program advocates for safe, effective, and appropriate treatment, the essential to all of this is to ensure that the biosimilars policies are made using a patient-centered approach, whereby the needs and the treatment goals of the patients are taken into consideration, along with the nuances that the field of ophthalmology brings, which is not, of course, similar across other therapeutic areas. So taking those nuances into consideration when developing the policies, and ensuring that both patients and physicians alike are educated to ensure confidence and uptake of the treatments is crucial.
Look, thank you very much. Clearly today, this is our contribution, one of our contributions to, Vision Health Month in Canada. We also have conducted a very inspiring interview with Dr. Keith Gordon, a senior advisor from the Canadian Council of the Blind, that will be available to you. And we ask you to, as Sylvie said, work together. And so we thank Sylvie Castonguay from the Quebec Association of Macular Degeneration. Sylvie, thank you very much for being with us today and really sharing the real life experiences with us. Mr. Michael Riley, it's always a pleasure to listen to you, to hear you, to talk with you, because your experience not only, in this field with ASBM, but really your background in advocating for change is just critical to our path as we move forward. And so we need to continue to fight the good fight. And I say that because without our voices across sector and across disciplines, and that's with healthy aging people too, we are not going to create the opportunity for change. So policies may be in place. That doesn't stop us from having dialogue and actually raising the issues. Education, consistency, transitioning from biologic to biologic. What does that say? Biologic to biosimilar. The ethics of consent in switching. Patient needs to be, they need to know that this is happening. And of course, the whole area of exemptions that we may touch on in the future. So thank you very much for being with us today, and also for your patience in my technical expertise, which needs some refinement, and also to Luana Colnago for being with us today. So thank you one and all, and we'll speak to you in the very near future. Vision Health Month is in May. All the best. Bye-bye.
Thank you all.